So without further ado, I'm going to introduce Dr. Marissa Raymond-Flesch. She is a professor in the Philip Arley Institute for Health Policy Studies and the Division of Adolescent and Young Adult Medicine within the Department of Pediatrics here at UCSF. She completed her undergraduate degree at MIT, her medical degree at Cornell, and her public health training at Columbia University. Clinically, she practices adolescent and young adult medicine with patients 12 to 26 years old, including serving as a physician in UCSF's eating disorder program. Her work is deeply motivated by the challenges that her patients face, and her research focuses on the most urgent issues in adolescent and young adult health today, including ensuring equitable access to mental and reproductive health care for youth and investigating new medications to treat patients with eating disorders. She is the principal investigator of UCSF's study for psilocybin for anorexia in young adults, also known as SPANIA, which we're going to hear a little bit more about towards the end of today's talk. And today she's going to be speaking about, what prior research can tell us about psilocybin and anorexia, looking at how psilocybin might be able to target cognitive rigidity that we see in AN, and also how she was inspired to develop SPANIA. I am personally grateful to work alongside her and learn from her and her passion for this work. Her heart and dedication to helping her patients is truly inspiring. So thank you, Dr. Raymond-Flesch, and welcome.
Thank you for that lovely intro and for all your hard work in organizing tonight's event, Brittany. In beginning this talk, I was thinking a lot about my patients, our patients. I think many of the people on today's webinar are healthcare providers, our family members, or people, and perhaps our people who have struggled with anorexia and other eating disorders. And, I do both inpatient and outpatient care. And when I am meeting a new family who is beginning the battle with anorexia, I often tell them that this is a war lost in the bread crusts, that every bite matters. I tell them about how this disease has the same fatality rate as the most common form of childhood cancer. And I do all of those things to do my best to mobilize families to help treat their loved ones, their kids with anorexia. And it is a wildly difficult ask of families. And one father that I was caring for once told our practice that, there we go, that no one asks parents to give their children chemotherapy at home. And, really made the point that the ask was so big, it felt next to impossible and certainly felt unfair. And I really agree with that. The way that we ask families to refeed their kids is incredibly daunting, and it's just not possible for all families, as we'll talk a little bit more about. And so as a healthcare provider, I feel like it's a moral imperative of ours to continue to explore new treatments, even when they seem really outside of the box. Brittany asked me to say a little bit about how I came to do this trial. And I think, like many of you, I lived through watching the suffering that our kids, our young adults, witnessed and endured during the pandemic. These are the numbers for UCSF. Our hospitalization rates more than tripled during the pandemic. It was the first time that we found out that we could only admit 14 patients at a time to the hospital because we didn't have the capacity to care for more than that. It was an incredibly daunting tidal wave of suffering, and it stayed this high for a very long time after the pandemic waned. And, as I think back to that period, I sort of think about not just what this tidal wave was like, but what the day-to-day practice was like in caring for patients who were suffering that much at that time. As many of you might be aware, this was a period in which there were more of them, but they were also presenting more psychologically and medically ill than we had ever seen before across the United States. And caring for them and asking their parents to do that work was, I think, sort of beyond the capacities of what our system could endure at the time. And I remember one patient in particular who at that time was in her middle adolescence, maybe 16, 15, and she was not able to eat and she had to eat to live. Her heart rate was very low, and we needed to place a feeding tube to feed her. And it was difficult, and she was very understandably distraught. And she actually spit out and bit holes in that feeding tube because she wanted so badly to die. My patients don't usually want to die, but she did want to die. And in that moment, I really thought about how much this must be what parents feel like every day. How when they cannot get a child to eat at home, they don't have a lot of other options. And it was a very rare moment of powerlessness for me as a healthcare provider. But what I know to do in the moments when I feel powerless is I ask myself, what power and privilege do I have? And am I using it to the best of my abilities? And this was also a period while there was profound suffering happening that we were starting to see some new breakthroughs in science. Right about this time was when some of the early studies on the long-term phase 3 trials for PTSD with MDMA were coming out. And we were actually not just seeing those results, but we were also seeing some of the phase 2 trials and the durability that we were seeing in patients recovering. And I remember being particularly struck by the fact that this was a very, very sick cohort of people who enrolled in this trial. And two-thirds of them had substantial clinical improvement, and that clinical improvement stayed. And this was really unlike anything that I had ever seen as a physician scientist in a behavioral health trial. Normally in behavioral health trials, we take away the intervention and we see what we call regression to the mean. Suffering resurges, people get sick again when they don't have the same supports that they did. But these new medications were doing something very different. And around the same time, we started to see trials with alcohol use disorder. And I was particularly interested in this because substance use disorder has some common underlying themes with anorexia. We know that there's actually some genetic predisposition that overlaps between them. And we also know that these are two sets of disorders that are called egosyntonic illnesses. They're illnesses that get very close in to people's identities and they become very hard to let go of. And I thought, gosh, if psilocybin can help people with alcohol use disorder, could it do something for my patients? And I have to say, I know there's a lot of different people on tonight's webinar. As I said, many healthcare providers, some family members, some patients. Um, it was so hard for me to make the leap to do this study. I grew up in the middle of the war on drugs. I'm a Mexican American who was literally DARE Student of the Year back in the 80s. But we need new tools so badly that I had to put all of that down and really start to ask myself what might be possible. So on our agenda today, I'm going to very briefly touch on the current treatment landscape for anorexia nervosa. I trust that most people on this webinar know that material quite well. I'm going to talk a little bit about our evolving understanding of the neurobiology of anorexia. We're going to move to some of the mechanisms underlying that and how we think psilocybin might be helpful. I'm going to end talking about the current research, what's been published, what we're doing at UCSF, and then I'm really looking forward to your questions. So as people on this call are probably quite aware, the mainstay of treatment right now for anorexia nervosa is psychotherapy. The strongest evidence base is for family-based treatment, which focuses on empowering families to help with weight restoration and takes a very agnostic view of the underlying etiology of this illness. And it is one of the best tools that we have, and still sustained remission occurs for less than half of young people who do this. And it's very high demand. It's very, very high demands on family. It's not widely available. It's often not covered by insurance, and it can be quite expensive. It is also often not available in the languages that all families need it. There are other therapeutic modalities that help in some cases, cognitive behavioral therapy, dialectical behavioral therapy, all take a more individual approach, though some DBT involves family. And these are often also used for young adults or adults, or when FBT is not possible for a family for some reason or not available. But again, remission rates are low. And then the question of psychopharmacology. No medications to date have been proven to be effective for core symptoms of anorexia nervosa. There's a little bit of data suggesting that second generation antipsychotics, those with dopaminergic and serotonergic modulation, might have some benefit in terms of weight gain, but the signal is weak at best. And there's some evidence for fluoxetine. Really, the evidence focuses on binge purge episodes in bulimia, but it is sometimes used off-label in anorexia as well. And the thing that's really challenging is that unless some evidence-based treatment is provided within the first 3 years of illness onset, we do know that outcomes tend to be poor regardless of access to treatment after that. And so, as an adolescent and young adult physician, I really want to see us moving new evidence-based treatments into younger age groups as soon as it's safe to do so. And, this is because anorexia is such a dangerous illness. Depending on the source that you look at, it has somewhere between a 6 and 10% mortality rate, which is a mortality rate similar to acute lymphoblastic leukemia, the most common form of childhood cancer. This is twice the mortality rate of schizophrenia, 3 times that of bipolar disorder. And it also just has very long-term debilitating effects. 20% of adolescents who are hospitalized with AN will struggle to support themselves in young adulthood. It has really devastating consequences for some young people on their long-term ability to achieve their life goals. Now, I really don't want to leave people in a hopeless place. This is actually a very, very hopeful talk. And so I think it's so important to recognize what an exciting moment it is in our scientific advances related to treating eating disorders, anorexia, and others. I'm going to focus obviously today on psilocybin, but there are other psychedelics that are also being investigated. UCSF has another study going related to ketamine on our inpatient unit. As I'll go through later, there's some limited data on ayahuasca and MDMA as well. Then there are entire other modalities that are being explored. There are multiple new types of neuromodulation, including TMS and TDS and vagus nerve stimulation, which all suggest possible benefit for patients with anorexia. And then, of course, new therapeutic adaptations, investigative diets, and others. There is a lot of hope for new treatments. I really want anyone who is suffering, who's listening to this podcast, to this webinar, to really leave with that idea. New treatments are coming. So let's move on to the neurobiology of anorexia and eating disorders. In this section of the talk, I'm going to lean heavily on some amazing work and some really great review papers published by Claire Folty and her group in Australia. And I really recommend them for clinicians or any neuroscientists on this webinar that want a deeper dive into the mechanisms. I'm going to try and keep this accessible to everybody, but if you really want a good read, go find Claire Folty's papers. They are cited in these slides. So I think one thing to recognize is that we are really starting to painstakingly pin down the neurobiology, and it is complicated. The regulation of hunger and drives for hunger and satiety are a complex dance between the brain, the gut, and the environment. And that interplay includes not just the gut-brain axis, the vagus nerve, its stimulation of the gut, the neural peptides and hormones that many people have heard about in other contexts right now, like GLP-1, ghrelin, that are making the news for other therapeutics right now. But all of that sends feedback via the vagus nerve and via hormone relays up to the central nervous system, where much of this is processed. And we know that those higher order processing really mediate signals of hunger and satiety through a couple of different systems. Sorry about that. One of them is the amygdala, which really processes the emotional aspects of food and the salience of food. And then there are 2 other major pathways related to sort of neural processing of food and hunger. One of them is the mesolimbic dopamine pathway. And this is really about like the pleasure of eating, the hedonic pathway of feeding and eating. And then the other is the hypothalamus. And this is really just about the scientific word is homeostasis, the regulation of the body and food intake and how much food we need in order to run our bodies appropriately. And all of these systems can be overridden by higher order cognitive functions in the most developed parts of our brain, the prefrontal cortex, for example. And that's actually part of the way that anorexia goes awry. So, what we know about the neurobiology of anorexia in the big picture is that restrictive eating reduces negative mood. That negative mood is caused by a dysregulated or abnormal interaction between the inhibitory system, which is run by serotonin, and the reward system, which is run by dopamine. We need a balance of inhibition and reward to help us eat and listen to our bodies when we need to eat. Our neuroimaging suggests that these dysregulated pathways change the awareness of what the body needs. So essentially in anorexia, there's a dampening of listening to things like hunger signals and other negative stimuli from the body. It's one of the reasons that my patients might run through shin splints or genuinely not feel bad when they are starving. It's because these pathways that are very far in the most front and developed parts of the brain can kind of shut down and ignore signals from other parts of the body. And then in anorexia, we also know that there's just really strongly enhanced executive ability to inhibit incentive motivational drives. And what that really means is, as I was saying, these most developed parts of the neocortex can sort of shut down worries about hunger, about whether they want to do something, need to do something, and really focus on other things like the SATs. So here are a couple of circuits that Claire Foldy presents in one of her other papers that really show the overlay between anorexia nervosa and a couple of really key neurocircuits. One of them is the executive control network. And again, that's the circuit that's highly developed that can override other circuits in the brain related to hunger, pain, things like that. And then another group of neurocircuitry that I'm going to introduce and talk more about is called the default mode network. The default mode network is a really important network that guides how we think about ourselves. This is kind of where your brain might spin when you don't give it something else to do. And I think many of us have had the experience or had a patient who might get stuck in different ruts in their default mode network. It's not uncommon for my depressed patients to tell me that they get stuck in ruts where they feel worthless. They think life may not be worth living. My patients with eating disorders might get stuck in ruts where they're really, really concerned about different parts of their body or about how they look or how others might perceive them. The default mode network can be a dangerous place to sort of spin, especially when spinning on very, very negative thoughts. One of my colleagues here at UCSF uses the metaphor of ruts in the snow, the default mode network. You can develop these very, very deep ruts in the snow that are very hard to shift out of. You can imagine the deeper those ruts get, the harder it is to change course. And what we think is that there's a feedback loop that promotes these ruts in the road, cognitive rigidity, and malnutrition. And so our patients start with an aberrant default mode network. They become more and more cognitively rigid that feeds back into a distorted body image, resulting in restricting and overexercising, which causes them to be more malnourished, which seems to worsen the aberrant default mode network activity. And it's really a spiral that's very hard to pull out of. And we are hopeful that psilocybin might be a medication that shakes the snow globe, as my colleague says. It takes those ruts and shakes things up and gives things a chance to fall into new patterns. And I'm going to go through now some of what we know about psilocybin and some of what we are hoping will be true for patients with anorexia. So, as I was mentioning, anorexia nervosa has, we know, decreased serotonin or 5-HT2A binding that causes this overactive default mode network that leads to cognitive rigidity, obsessionality, adversive reward systems, behavioral inhibition. And this molecule that I have a picture of here is actually what serotonin looks like. And one of the things we also know is that when you're starving, you don't make very much serotonin. You have to be taking in a wide complement of proteins and getting plenty of tryptophan, which is the precursor to serotonin, in order to make it at all, which is why things like serotonin reuptake inhibitors, SSRIs, don't work terribly well on our patients. If you don't have serotonin, there's nothing to keep in the synapse. Those medications don't have anything to work on. Psilocybin bypasses this problem. Psilocybin directly activates the serotonin receptors, the 5-HT2A receptors. And by doing so, it actually really quiets the default mode network. It stops that spinning. And that allows for increased connectivity across the neocortex, and the potential for increased plasticity or new connections to be made across the brain. And one thing that's really exciting about it for patients who are malnourished is that they don't actually need to have any serotonin in their bodies for psilocybin to work. I put the picture of both molecules on there so that you can see how similar they are. Psilocybin just acts exactly like serotonin and kind of locks into that receptor, even when the body can't make its own serotonin due to malnutrition. So people, when talking about psychedelics, often discuss this concept of plasticity. And plasticity is really about changes that can happen at the level of the neuron and in the brain. Acutely, when people are actually taking a psychedelic and having the altered state of consciousness that comes with it, it causes a profound increase in connectivity across neural networks. And the picture up top right here shows what a normal resting brain looks like. Normally, our brains are very efficient. We don't really want them having thousands of extra connections that they don't need a minute. In a normal state, this is very efficient. We want them to have strong pathways for the things that they use regularly. But for the purposes of the therapeutic intervention of psychedelics, while you're acutely intoxicated with a psychedelic, what happens is these walls come down and there's profound interconnection across areas of the brain that haven't talked to each other in a long time. It's part of what gives rise to the altered state of consciousness, but we think that it is also part of what gives rise to the potential for neuroplasticity. And in the short term thereafter, from animal models, we know that if you bathe a rat neuron in psilocybin, it actually will grow and shoot out new dendrites, new connections to other nerves. And this is from like a single exposure to the medication. So really profound potential for change, both kind of in terms of connection across the neocortex, but even actual change to neurons. And this is what we're hoping and we believe gives rise to the potential for behavior change and symptom change for patients with severe and enduring mental illnesses. And so how does that look clinically? Well, one of the mechanisms that we're most interested in for patients with eating disorders is the idea of cognitive flexibility. Cognitive flexibility is really the ability to adapt quickly and learn new rules, new tasks to shift gears. The opposite of cognitive flexibility is cognitive rigidity. It might be things like having really specific rituals or rules around foods, what foods you will eat, what foods you won't eat in our patients, for example. And in this case, I'm presenting some data that we know from some of the depression trials that have been done with psilocybin. So the top graph is showing decrease in depressive symptoms across all of the participants in this study. And the second graph is showing a reduction in the number of mistakes they have on essentially a computer game that they're doing that requires them to continuously learn new rules. So the cognitive flexibility task is continuous adapting to new rules, and the less mistakes they make, the more quickly they're learning. And you can see that over time, on aggregate across this study, after a couple of doses of psilocybin, people were faster and faster on this task. And I will say that this is a special task that's designed so that you can't just learn. There's kind of a rotating series of different sorts of rules you have to learn at random. So it's designed to be repeatable. And I want to particularly highlight as we transition to the next part of this talk that these research findings and all of the findings that I'll be presenting later on are about the effects of psilocybin therapy, sometimes called psilocybin-assisted therapy, on mental health and well-being. And I really want to focus on this because I want to be very, very clear that psilocybin, the way that we are studying it and the way that most people study it, is not a drug that is just administered on its own. It's a drug that is administered with formal and structured psychological support as well for our patients as like significant medical monitoring to ensure safety related to the sequela of malnutrition. So at this point, I'm going to shift gears and talk some more about current research and what we know already. So the questions that I get most commonly are, what does psilocybin therapy actually look like in practice? And is it safe? Is it safe for me, for my patient, for my daughter? Is it safe? So this is the general structure of the psychedelic assisted therapy model. Generally, patients will need to come in and complete quite a bit of medical and psychological screening to ensure that they're safe to proceed. They will have some amount of preparatory therapy, which largely includes a lot of psychoeducation about what to expect, as well as intention setting. I'll talk a little bit more about the therapy modality, but it's very client-driven and non-directive. These models have anywhere from, I think right now, anywhere from 1 to 4 dosing sessions, depending on the study protocol. And after each dosing session, there's some amount of what's called integration therapy, where clients meet with their therapists, they consider the intentions that they went in with, they think about what their experience was during their dosing day, and they begin to make sense of how that fits into their lives and their treatment going forward. In terms of the psychotherapeutic elements, I will of course say I am not a therapist. I'm a medical physician, but have been working very closely with an amazing team here at UCSF that includes team members from our psychedelic assisted therapy research group and our eating disorder program. And we have designed a protocol that really draws on the major tenets that we know of so far in effective psilocybin assisted therapy. So this treatment protocol at UCSF, and generally the ones that have been published to date for patients with anorexia, are highly self-directed. This is definitely not FBT. They are really focused on mental health, and I say that to distinguish them from interventions that are focused on weight or nutrition related to eating disorders. And they are highly trauma informed. At UCSF, we kind of assume high comorbid rates of trauma, particularly medical trauma for some of our patients with severe and enduring illness. And I really want to say quite humbly that we have so much to learn about what the optimal psychedelic assisted therapies will be for eating disorders. In the world of addiction medicine, they're just starting to bring in some more manualized principles related to ACT and other forms of therapy. I think we really have far to go still, and we're still focused largely on safety considerations, but this is going to be an area of research for at least another decade as we sort out best protocols and best protocols at different age groups. And then, of course, anorexia is not just a psychiatric illness, but also has significant medical sequelae. And so some of the medical considerations that are particularly important when thinking about psilocybin are that our patients who are malnourished often struggle with headaches, dizziness and lightheadedness, low blood sugar, nausea, constipation, EKG changes, lower heart rates, and lower blood pressures. And psilocybin impacts all of these issues. So we know that actually headache is one of the most common side effects of psilocybin. And we see it very commonly in research studies. Psilocybin also causes some dizziness, some lightheadedness, some unsteadiness on one's feet that have to be managed during psychedelic assisted therapy. The one research study that's been published to date that I'll go over in more detail in a few minutes did find hypoglycemia as their main adverse event. These medications are often taken over a long period of time. A psychedelic assisted psychotherapy session with psilocybin, a dosing day might take 6 hours or more. And many times participants are not naturally driven to eat during that period, but that puts them at great risk for low blood sugar. Psilocybin has another common side effect of nausea that we need to manage with patients in clinical trials. Luckily, it primarily increases blood pressure and heart rate, so those don't stack in a dangerous way for our patients. And there's some suggestion that it may cause longer QT changes, but we are still learning a great deal about that. And I'll put in a plug for a paper that Amanda Downey here led about sort of the medical considerations of psilocybin and severe malnutrition and anorexia that I would welcome you guys to read and that we can put into the resources for this study if you're interested. I really want to hammer home the fact that anorexia is both a medical and a psychological illness. I think a lot of people are hearing more and more about the incredible results that we're seeing for psilocybin in other mental health problems like depression. But no matter what we do in a psilocybin dosing session, psilocybin cannot immediately resolve the medical consequences of malnutrition. Instead, the way that I think of it is that it might make change in behavior and thinking possible for patients who have really been stuck in those ruts for a long time. So what do we know so far? The one published trial to date is out of UCSD, and it was published in Nature Medicine, and it was a single dose open label trial of 10 patients. I mentioned earlier that the kind of only significant adverse event that they had was hypoglycemia in a couple of their patients. And they used the primary outcome was the EDE, and based on global scores of the EDE, they found that about 6 out of 10 of their patients were in remission at 3 months follow-up. Though when they started, 2 were already kind of not quite meeting the threshold of officially of their EDE threshold. So it was really 4 patients who recovered during the trial. There's some other data supporting this. This is from a review paper from last year that went through kind of available data. There's a lot of case reports and some cross-sectional data that is with other classical psychedelics. Adolescent has done some work outside of the United States with ayahuasca, which is another psychedelic that works on the same pathways as psilocybin. And otherwise, it's just the UCSD trial in terms of clinical trials that have been published to date. I do expect any day now that we will see data from Imperial College London and from Hopkins, who have both completed clinical trials with patients with anorexia nervosa. Those populations are older than the population that we're working with at UCSF. So I will wind down our kind of slide presentation by talking some about UCSF's clinical trial. You'll hear people call it SPANIA, or the study of psilocybin for anorexia nervosa in young adults. Our objectives in SPANIA, the primary objective is to assess the 28-day treatment efficacy of psilocybin on symptoms of anorexia nervosa using the EDE, or the eating disorder examination. And the only kind of physical measure that we're following is percent treatment goal weight. Secondarily, we are heavily focused on safety in this clinical trial, including monitoring vital signs, electrolytes, and electrocardiograms. And we really want to look at whether psilocybin is changing cognitive rigidity in our patients, and we are doing that through a few different measures. We're using the PIN conditional exclusion test, which is the same test that was used in the depression trial I presented earlier. And then we're also using fMRI, which is sort of real-time functional neuroimaging, giving our participants tasks to do and watching blood flow in their brain as they do it to understand how that is changing and evolving after taking psilocybin. I will present a few of our inclusion and exclusion criteria, and I want to also be honest in saying that our trial and most trials don't publish all of their inclusion and exclusion trial. I will not, for example, share our exact cutoffs in terms of medical stability. We really don't want to make anyone feel compelled to do anything to change their vital signs to get into the trial. And that is some of the reasons why we're not publishing every detail. But generally, we are recruiting 18 to 25-year-olds of any gender who meet DSM criteria for any subtype of AN. That includes restrictive, binge purge, or quote unquote atypical AN. They need to have had some other attempted treatment that was eating disorder focused. It could be psychotherapy of any kind. It could be residential therapy. It could be PHP or IOP. We just don't want this to be anyone's first line treatment. They have to have a BMI at least of 12, and we are dosing people who have been pretty low. They have to be able to the young adult has to be able to participate in English, and they have to be willing to abstain from other substances for 48 hours pre and post dosing. And if they're able to get pregnant, they have to use some highly effective form of contraception. In terms of exclusion criteria, we cannot dose anyone who might be pregnant or breastfeeding. If people are too unstable in terms of their vital signs, we cannot dose them. And there are multiple checkpoints in the study, both during the screening phase and then prior to each psilocybin dose, to assess vital sign stability. If someone is unstable, we consider that sort of a temporary state, and we work with them to try and help them stabilize so that they can continue in the trial. If some of the lab work is too abnormal and we're not able to help them correct it, then we cannot bring them forward in the trial. If they have significant EKG abnormalities or cardiovascular disease, we can't bring them forward in the trial. If they have a seizure disorder, bipolar depression, chronic psychosis, or severe or moderate substance use disorder within the past year, they cannot participate in the trial. But I think it's so important to remember, especially for the substance use disorder, that the trial will be going on for a couple of years. And if people are not eligible right now, they may be eligible in the future. So just to keep that in mind as healthcare providers. And there are certainly a long list of contraindicated medications. We offer to work with participants if they are willing to taper off of medications. And importantly, it is okay for participants to stay on their SSRIs or SNRIs, which are some of the most common medications our participants come to us on. Additionally, and very recently, it became okay for participants to remain in therapy with their outside psychotherapists, which I'm hoping will provide an additional layer of support and encouragement during the trial for them. So Spania looks a lot like the other clinical trials I was describing. We have an extensive screening process. We are hoping to recruit 40 young adults into the trial. We have we're only about 10% of the way through now, with more participants coming through. And they all will be offered to do neuroimaging as well, though it's not required if there's someone who's quite scared of being in small spaces. It's not required, but it's something that we're doing for part of the trial. And there are 2 dosing days. And another common question I frequently get is about whether these are microdoses or macro doses. These are definitely macro doses. People have a full psychedelic experience on these doses. It is, as I said, often 6 hours, sometimes a little bit more of an altered state of consciousness. So it's quite a significant experience that really does require the processing of the psychotherapy that comes after it. No participants in our trial will receive placebo. And then I'll say just a little bit more about kind of our philosophy and research approach to share with you guys. We really think of I am someone who thinks of clinical trials and needs them to be designed pragmatically so that they might be as implementable in the real world as possible. And so as we were thinking about Spania, we wanted to be thinking about our potential patient or research participant at the center, but really recognizing that they exist in a larger ecosystem that includes their families, their therapists and other healthcare providers, and then the structural factors that inhibit or help them access care. So in order to sort of center the patient and their family, we are working hard to center lived experience in this trial. Spania is informed by both a young adult advisory board and a parent advisory board. Those advisors are helping us with study design, with implementation challenges, with improving our recruitment and outreach strategies. And I will make a plug for saying that we really welcome additional advisory board members. These generally have to be people who wouldn't be eligible for the trial. Maybe they're too far in their recovery or they're older than we could enroll. But we really welcome additional people as the young people who are on our advisory board and the parents are very busy and some roll on and some roll off over time. Um, we are asking all of the young adults who enroll in this trial to bring two support people with them. And this is probably the piece that I get the most questions about from the young adults themselves. Some young adults are bringing parents, some bringing spouses, siblings, close friends, other relatives. And the purpose of the family therapy is to really help people. Well, as one of our parent advisors said, you have to teach them it's not FBT. This is really not FBT. And so in our family therapy, we're trying to take a very trauma-informed approach. Again, we really recognize the amount of medical trauma, if not other trauma, that families have faced in their treatment for anorexia. And then there's a big focus on psychoeducation about psychedelic assisted therapy and coaching parents in emotion-focused therapy strategies, EFT, which is just really a structured validation method for giving them a new tool to support the young adult through the clinical trial and giving them something that's not FBT to do. We also have tried to build this trial thinking about community engagement at a broader level and really thinking about the healthcare providers that we're going to be collaborating with for referrals into this trial. And in the longer term, as people come in and out of these research studies and perhaps eventually clinical interventions in settings like UCSF. So thank you to some of you who are on this call. I know some of you participated in the focus groups that we did a couple of years ago before we launched Vanya, where we went out and asked physicians and psychotherapists and other healthcare providers what they need in order to collaborate with us to do psychedelic assisted therapy safely. And they wanted to know who to refer, more information about protocols. During the psychedelic assisted therapy, they wanted to be able to provide collateral information and get updates. They suggested the possibility of a written summary prepared by the client. And after psychedelic assisted therapy, they wanted to be able to access intermittent consultation and had hopes that we might someday run formal consultation groups or follow-up groups for clients, and asked us to begin curating publications and running workshops that might be helpful. And very honestly, today's webinar is one of those efforts. And then the last thing I'll say about our trial design is that we have a really strong commitment to health equity at UCSF. I did a study a couple of years ago looking at what our patient makeup looks like. And of course, it's not what people picture when they picture eating disorders. Our patients are incredibly diverse. 45% of our patients in our eating disorder program are not white. Many of them don't speak English. And so for this trial, we also have some Spanish language capabilities, especially for parents. And really want to make sure that we are trying to enroll and reach out to the most diverse populations that we can so that everybody has access to these trials in addition to hopefully access to these treatments later on if they are helpful and safe and effective. So with that, I will sort of put up this slide. I'm sure that people have questions. I'm really looking forward to hearing your questions and engaging with you about them. If you want to learn more about the trial itself, this is a QC code that you can use to go to a website with more information. And if you are interested in enrolling in the trial or finding out more about that, there's a questionnaire on here for anyone who wants to begin the screening process for the trial or wants to share that link with patients or loved ones. You are really, really welcome to reach out to me with any questions or our study team, who is incredible. And I think Brittany is popping back on here to help me navigate some of the questions that you have. But she is one of the study team members that you would reach if you emailed us at psilocybin.anstudy@ucsf.edu. And with that, I'm going to